Chapter 12 covers the patient's primary assessment. The primary assessment begins after you do your scene size up of your BS man. Initially, you want to focus on life threats, anything that sticks out that if you do not intervene immediately is going to end up being the demise of the patient. Otherwise, you focus on the ABCs, the airway, the breathing, the circulation. All this can come into play depending on if you have several people or if it's just you and another partner. For instance, if you respond with a couple ambulances or you're there with the fire departments, different things may happen simultaneously to where you may not be the only one doing a full assessment. Otherwise, you need to focus on, like I said, those life-threatening priorities come before airway, breathing, circulation. For instance, you show up and there's major blood loss. You need to control that bleeding before you worry about the airway. Those red blood cells and hemoglobins on the ground aren't going to help any with the patient's airway if you don't keep the blood cells in and stop that bleeding. That order of those ABCs is just dependent on those life-threatening things. Say if it is life-threatening enough to where you think they're fully dead, then you start with circulation, airway, breathing. So for instance, if they appear to be dead, you worry about getting a circulation, starting those chest compressions before you worry about giving a breath. But a good rule of thumb is if they appear to be dead, just assume that they are and start from there. This doesn't mean that if they appear to be dead, you start CPR. It just means that you want to go and check for circulation, checking for pulses before you go to that airway. By going to the airway, it needs to be cleared. So if you go to the patient and there's gurgling sounds, you need to make sure you create that patent airway by suctioning, removing foreign bodies, whatever you need to do, make that airway patent. The rest that the breathing and the circulation are very important to sustaining life, because without those there cannot be life. So you need to make sure you have that airway patent so breathing can happen and for circulation to do its job. And with exsanguating bleeding, that means really, really bad bleeding. The bleeding that's going to just be very difficult to control, because the ultimate goal for controlling major traumatic bleeding is surgery. Once you do begin that primary assessment, if you don't see any major life threats such as death or major bleeding or major airway compromise, then you are in a less urgent mode where you can start just by giving oxygen, doing a more detailed assessment as it goes on. So the biggest thing is just to know to treat those life-threatening injuries first. So after you've done your BS man, you do your scene size up and your scene survey, got your BSI, scene safety, mechanism of injury, your nature of illness, additional resources needed, and number of patients. Then that's when you form that general impression of the patient. As you come up, what do you see? How does the patient present from a distance? That's before you've even made initial patient contact. Next is that mental status. So generally, a lot of times that mental status and airway and breathing can kind of almost correlate together. One of the best things to do for patient size up is to just begin talking to them. So as you go and talk to them, say, hey, what's going on? Why are you calling today? Introduce yourself. And then with that, you can kind of get that mental status. If they're able to tell you everything that's going on, they know how long it's been bothering them, or as we say, conscious and alert, that means that they've got a good mental status. Otherwise, if that general impression, they sit there and they look that they appear to be dead, then that brings in that immediate urgency. You need to react. Otherwise, general impression, that mental status, are they alert, not, confused, they unresponsive, whatever it may be, and then you go into your ABCs and then determine patient priority. So all of this should only take just a matter of a few seconds to go down through your general impression, the mental status, and the ABCs, as long as you can talk to them, touch them, checking pulses, checking skin conditions, everything like that. And then once you get that general impression based on your gut instinct, that mental status, and assess the A, B's, and C's, Then you determine that patient priority, meaning, can you stay and play with them, or do you need to get out to the ambulance and get to the hospital quick? So my little saying is, sick or not sick? If sick, how quick? That will determine your patient priority. When you do that general impression ABCs, like, well, they seem pretty stable, everything else checks out okay, that means you don't really have to express much urgency. But if you've checked all those and there's major compromise of the airway or circulation, or they have an altered mental status, that means they're sick, you need to go quick. As you gain experience, you'll be able to deem that patient critical a lot of times just from that general impression. So some things that can key into being a critical patient is, well, obviously death and altered mental status. Always pay attention to altered mental status and knowing that if it is truly altered from their normal, they may always be confused or not be in their normal right mindset. But anybody who does have an altered mental status from their normal is a very bad sign. Also, some other things to go in, just how the patient presents. If they have anxiety, they've got very warm or very sweaty or diaphoretic skin, any major obvious trauma, that car wreck with ejection and the person's laying on the road and their foot's beside their head, obviously that's a critical. Major any compromise to the airway or the breathing, or just how the patient can present with their body positioning, showing Levine sign, that tripoding position for difficulty in breathing, and just other general impressions as patients are going to give you just from how they react. So you see here some examples of those general impressions of body mechanics. So Levine sign, just clutching of the chest for chest pain, the tripoding position. You see the gentleman in the picture here having those intercostal muscle retractions. The muscles in between his ribs are sucking in. He's got his hands on his knees, tripoding position, using muscles in the neck. You start seeing those little indicators knowing that that's a critical patient. And then altered mental status. Somebody who's laying there unconscious, very bad sign, that is a critical patient. Next is that chief complaint. So whenever you're going up asking them, hey, why'd you call today? What's going on? How you feeling? Tell me about why you called 911 today. You're generally going to get just a chief complaint from that. So it's not necessarily going up saying, what is your chief complaint, like a robot. You need to just talk, interact with the patients, and you'll get those answers out of them. So sometimes they can tailor responses, or you may have to kind of tailor questions to get more out of them whenever they say something vague, such as, I'm just not feeling good. Or it could be specific that my chest hurts, it's going into my shoulder and my neck and going into my back. Very specific stuff. Sometimes these patients who call 911 know all the questions and a whole gamut you're going to run them through, so they've got their answers and everything ready for you. That general impression, you need to use your senses, use all your senses except taste. You don't really need to go up and lick your patient or taste any kind of fluids come out of them. Otherwise, look, listen, touch, smell. So look at the patient. How are they presenting? What's their disposition, their age? Most often a 96-year-old person having difficulty in breathing could be worse than the 25-year-old having difficulty in breathing, or those chest pains, things like that. So listening, if you hear any crazy airway or breathing sounds, you hear any kind of noises coming out of their lungs without a stethoscope, or you hear that they've got a slow or slurred speech, or they sound really raspy like they could have an upper airway issue. Smelling, if you got any kind of BO or just weird body smells coming off of them that don't appear to be normal, or any kind of just environmental things that you're smelling, such as hazardous fumes or just other poor living conditions, anything that could contribute to that patient's condition. And then touching them. You need to touch every patient. As you go up, communicate with them, you touch and feel for a pulse every time. With that, when you talk to them, you're touching their wrist, asking them, hey, what's going on? When they talk to you, you've got their airway and their breathing, and by touching them, you're checking circulation. You're checking those pulses, you're checking the skin condition, see if they feel warm, everything else. And then check globally on them about if they may have a fever or if they have any edema, any kind of fluid buildup, or just any kind of weird skin changes. So when you're assessing your mental status, we use the acronym of AVPU. Alert meaning it's a person who's just sitting there, doesn't take any stimuli, they're wide awake, their eyes are open, they're looking at you. And with that, they're generally oriented to, as we say, person, place, time, and event. So alert and oriented times 4 is how we will generally document all that. And next is verbal response. That's not going up and just simply talking to them. That's yelling. If you yell, then that is a verbal response. So if you go up and even if you just talk in a normal communicating voice and then they open their eyes or respond to you, that's still them being alert. But if it takes you having to speak loudly, that's a verbal response. So if they're not alert and a verbal response doesn't work, we give them a painful response. That generally means taking your knuckles, rub into their sternum, pinch on the fingernail beds, do something to try to stimulate them. That doesn't mean go up and kick them in the groin or flip them in the eyeball. It means just doing some other subtle things that induce pain, see if they'll respond, move to that, wake up, whatever need be. And otherwise, if they don't respond to any of those, they're deemed unresponsive. You see here, going into a house, checking for signs of life. The person appears that they could potentially be lifeless, so they're going up and be worrying about checking circulation first, more so than just checking the airway. So with the airway, if they can speak in full sentences, they've got a patent airway. But if they start speaking in short sentences, and then they got to take a really deep breath in between words, that means that the breathing is not too good. So if you go up and they're talking to you, you hear air movement, they've got a patent airway. Otherwise, you need to do the head tilt chin lift or the modified jaw thrust. So with breathing, this is where interventions can start to come in. So if they are having inadequate breathing, simple thing of oxygenation. Having inadequate breathing, go ahead and put an on-air breather on if they are having breathing problems. If it's major breathing problems, such as not really breathing, then you need to ventilate them. So with breathing, generally the only thing you're going to worry about here is doing oxygenation and ventilation. Give them some O2 or breathe for them if they're not doing it adequately. Next goes into circulation. Now be mindful that circulation is what you check as the third after airway and breathing, and that's on your general medical patient that doesn't appear to have any life-threatening injuries. If they do seem to be unresponsive, life-threatening things, then you go to circulation first, but otherwise ABCs. So with circulation, you're going to check skin color, temperature, and condition, and for pulses. So you go up, you talk to them, you're feeling for that pulse. If you feel that radial pulse, that means there's good circulation there. And check pulses in both arms at the radial pulse point. Next with that, you're going to be checking for color and condition. So obviously you can just use your eyes to check for color, and then checking for temperature, you'll take the back part of your hand and touch it to their forehead, see if they may be fevered, if they're cold, if they're clammy, if they just feel sticky, whatever it may be. That's going to help you check all their perfusion status and anything else that could be causing an ailment for them. So indicators, if they seem to be unresponsive, this is where you go to first for pulse. You come up, you've yelled at them, you've given them pain, nothing's working, then you go straight to C's. Check for carotid pulse. As pulses start to go away, this is the last place you'll be able to feel a pulse on the body. Otherwise, your general medical patient checking that radial pulse. So when you assess a pulse, this is just a quick thing, knowing that how it feels, is it slow, is it fast, and then also with the other C's, controlling that major bleeding. Now if it's major life-threatening bleeding, you're going to take care of that before airway and breathing. But otherwise you get down and you've done your airway, your breathing, checking circulation. If there's bleeding and stuff going on, take care of that at that point. Unless it is life-threatening, then that comes first. So determining that patient priority, are they sick or are they not sick? If they're sick, how quick? Can we load and go, or do we need them to stay and play? So always some catchy phrases that go into it, but knowing that you really need to limit that on-scene time to less than 10 minutes. The sicker they are, the quicker you should be getting them prepared to get them to a hospital. That's the ultimate goal of what we're doing, is to get them to a hospital. And then that priority just kind of determines what kind of urgency you need to put into providing that patient care. If you have a little bit more time to stir up conversations with them, see how everything's been going on, and just kind of build that rapport with the patient, or if you just strictly need to focus on getting those interventions done right away. So you're treating those life-threatening conditions, and especially anything to that airway, breathing, circulation. If there's any issues with A, B's, or C's, that patient is unstable and they need to be rapidly transported. And with that, that doesn't mean going 110 miles an hour. That means just urgency, get them to the hospital, lights and sirens, more so than sitting there taking 25 minutes in the house to tell old war stories. And determining that priority may change. You may get that patient that you deem stable, and then once you get them in the ambulance and you continue assessments, they could go downhill. Or everything could seem okay through joint pressure and checking A, B's, and C's, and then as you later get into further and secondary assessments, you could find something else that deems them unstable. But the best rule of thumb, just go by your gut. If you feel like something is not right, just stick to your instincts. If your gut instinct or anything during your primary assessment reveals that that patient is unstable, you feel like that they could crash, they're going down the drain, or that they could potentially get to that point, that means immediate transport. And like I said, just always keep an eye on that, because that could always change. That patient could seem stable and then all of a sudden they just crash. And sometimes that happens. You have a patient that seems okay, I just got a little bit of chest pain, and all of a sudden they turn pale and cool, and then a couple minutes later they go into full cardiac arrest. So always be observing and assessing your patient.